It's day 3 of NEI Synapse, and we are here with Dr. Mago for an extended Q&A session. Let's listen in as he addresses your unanswered questions from today's presentation.
Today in my talk, I spoke about the practical management of side effects of psychotropic medications. I was only able to cover a few of them, but I hope that the listeners have been motivated to understand that there's a whole range of options, a menu of options that we have for each type of side effect, a level 1, level 2, and level 3, depending on how intensely we want to treat the side effect. Now, I was not able to get to some of the questions at the end, and so I'm going to try to answer these on this podcast. So let me jump right in. Would you expect akathisia to resolve after 1 to 2 weeks of mirtazapine without reducing the offending agent? Or would you treat with mirtazapine only while titrating propranolol? And so the answer to that is complicated, which is that I said that mirtazapine is an underutilized treatment for akathisia caused by antipsychotics. I also warned that don't use more than 15 milligrams because at low doses, 15 milligrams per day, it treats akathisia. At 30 milligrams per day, it causes akathisia. And so I just want to repeat that or reinforce that you have to use low dose. I said that an advantage of mirtazapine is that while propranolol requires titration, mirtazapine can be started on day 1. So the overall management plan will depend on the severity of the akathisia, and it will depend on how important it is that the person needs this particular medication. So let's say you give a person aripiprazole and they develop akathisia. You have to ask yourself, like, am I going to continue this person on aripiprazole or not? So if you made a mistake, as has happened in my patient was admitted to the inpatient unit. They put him on aripiprazole. They gave him 5 milligram. Then they increased him next day to 10 milligrams and the third day to 15 milligrams. Well, the person developed akathisia. I'm not going to give up on aripiprazole in this patient because the akathisia was caused by the too quick a titration. So that's the first decision. Am I going to continue this medication or not? So if I'm going to continue this medication or try to continue this medication because the titration was too quick, maybe I'll use a lower dose, maybe I'll temporarily reduce the dose, the severity of the akathisia is not too much. In those conditions, I start propranolol. So before starting propranolol, I always think to myself, am I going to continue the medication? I hope I have emphasized this point enough. There's no point starting a whole course of propranolol if you're not going to continue this particular medication, right? Now, while you're doing this, you're starting the propranolol maybe something like 20 milligram 2 or 3 times a day and then increasing from there. What can we do to give quick relief? One of the things you can do is give mirtazapine. The other is, of course, to give clonazepam. And so I would treat with mirtazapine for a short term while the propranolol is being titrated up and something is being done about the antipsychotic also. And then the person can be gradually, maybe reduce it to 7.5 and then stop. Because as you know, the disadvantage of continuing mirtazapine long term could be that it is very likely to cause weight gain. So unless there is some other reason why we want to continue mirtazapine, there could be potentially some other reason. But other than that, in terms of the akathisia, it is a good idea to use it only short term, if at all possible. So next question is, how much is disease process responsible for sexual dysfunction in contrast to medication? And that's a very, very good point, that we should not assume that the medication is the cause of the sexual dysfunction, because our illnesses themselves are responsible for a lot of sexual difficulties, especially decreased libido, but also other aspects of sexual functioning. So, for example, major depression being a typical example, but also anxiety disorders and so on and so forth. The other thing this question brings up is, what I've seen is when person has had major depression for a long period of time, let's say they have had significant depression for 5 years, 10 years, which is not rare in our patients, is it? It's pretty common. It's not so simple that after that, you treat the major depression and boom, they go back to sexual functioning like they did 10 years ago. They are 10 years older now, number one. Number two, having 10 years of depression has probably changed their relationship substantially, right? So the person who asked the question is correct in saying that the disease process, both in terms of like while it is acute, but even after recovery, can be involved in sexual functioning or causing sexual dysfunction, and we shouldn't assume that it's due to the medication. And then the last thing I want to say is that sexual functioning is complex, and in most cases my feeling is that it's multifactorial. if the person doesn't have underlying depression and anxiety, and if their relationship is good and they are excited about their partner, then even if they are on medication, maybe they won't have as much sexual dysfunction. It's all of the above. All of the above. And so, in treating sexual dysfunction, it requires a considerable amount of skill and attention to the illness, to the relationship, to the medication, and frankly, sometimes some attention to sexual technique. In this day and age, it may seem surprising, but to some extent, we have to coach our patients in that respect also. So, correct answer is all of the above. Next question is how to manage sexual side effects caused by antipsychotics. So, the second generation antipsychotics, which is what we prescribe most often, the reason why antipsychotics cause sexual side effects, the number one reason is hyperprolactinemia. There could be, again, many reasons, but like that is by far the most important reason why antipsychotics cause sexual side effects. So, the most important thing that we need to do if a person has sexual dysfunction due to the antipsychotic is to check the prolactin level. And if you find the prolactin level is elevated, and especially if it's more significantly elevated, let's say more than 100 nanogram per ml or more than 200 nanogram per ml, it's very likely that that is the cause of the sexual dysfunction. And especially if you see other features that are related to the increased prolactin, like for example, menstrual dysfunction or infertility and so on. So the question really changes then from how to manage the sexual side effects caused by antipsychotics. The question becomes how to manage hyperprolactinemia, if that is the number one cause, not the only cause, but the number one cause. And the answer to that is, perhaps consider changing the antipsychotics. As you know, the potent D2 blockers like risperidone or paliperidone are much more likely to cause increased prolactin than other antipsychotics. Now, I don't change from risperidone or paliperidone just because the prolactin level is elevated to 60 or 100. I get this question a lot. Like I have a patient, the prolactin level went up to 75 or 100 or something. What should I do? And the answer is do nothing. Perhaps do nothing. This is mild. But if the person has sexual dysfunction or other, bothersome consequences, then we may consider changing the antipsychotic if at all possible. That's probably the best thing. But let's say the person really needs the risperidone or paliperidone. They're doing great. We don't want to change them from this antipsychotic, but the prolactin is elevated. It's causing sexual dysfunction. In those cases, we can treat the hyperprolactinemia by the best single treatment at this time, other than changing the antipsychotic, is to add aripiprazole. You can also add bromocriptine, but we don't recommend that as unless other strategies have failed, because bromocriptine has a small possibility of worsening the psychosis. So adding the aripiprazole is important. You know this probably, the listener, that adding aripiprazole to another antipsychotic has been shown in multiple randomized controlled clinical trials to be effective for hyperprolactinemia. But there are two common mistakes that people make. Please listen carefully to what I'm going to say. There are two common mistakes that people make because of which this strategy fails, and they say, I added aripiprazole and it didn't work. The first is this idea that it is low dose aripiprazole. Everybody says the treatment of hyperprolactinemia is to add low dose aripiprazole. And of course, we know that aripiprazole should be started on a low dose and gradually increased, maybe at 2 milligram or 2.5 milligram, and then increased to 5 and all that. But please remember that you can and should use up to 20 milligram at least of aripiprazole, like a full dose of aripiprazole, 20 or God knows even 30 milligram, to treat the hyperprolactinemia. It is not true that hyperprolactinemia is treated by low dose of aripiprazole only. The studies have found that the people who got the higher dose were much more likely to benefit. So yes, we should try the lower dose. Yes, we should titrate up slowly, but go to a higher dose before concluding that it did not work. The other mistake people make is assuming that they give prolactin for like 3 days, 5 days, 7 days, and then they check the prolactin level and they say nothing happened. It takes some time for the effects to occur. So I would try for 3 to 4 weeks. You require 3 to 4 weeks before you will see a significant drop in the prolactin. So the other thing is not to be impatient. This is not an emergency. It may take a little bit of time to reduce the prolactin level. The devil is in the detail, as they say. And in order to succeed in clinical practice, we need to know all these details, which sometimes we don't get in the education we receive. We just hear use aripiprazole to treat hyperprolactinemia, but we don't necessarily get all the details about how to do it. Okay, next question. Antidepressant-induced excessive sweating. I coined this term many years ago when I did the first study of treatment of antidepressant-induced sweating. I used the term ADs, ADIES, ADs, and I'm very happy to see that it's coming up in the literature where people are referring to ADs. So raising awareness is something I feel very pleased about. So I had talked in my talk at NEI Synapse, I mentioned that glycopyrrolate is my number one choice for the treatment of antidepressant-induced sweating, and the other is terazosin, which is an alpha 1 blocker. But glycopyrrolate should be preferred because of higher safety, works quickly, and can be used PRN. All these things are not possible with terazosin. It doesn't work quickly, it cannot be used PRN, and it has the potential of causing orthostatic hypotension. Can these be helpful in a person taking doxepin, say 150 to 300 milligram of doxepin or other tricyclic antidepressants? So this is an excellent question, and do you understand like why this person is asking this question is because you have to try to think, is this person having antidepressant induced excessive sweating or ADs even though they are taking an antidepressant which is very anticholinergic already? So this is an excellent question. If they are taking an antidepressant which is already very anticholinergic, then you may have to think. That is why I always say if you have to use a tricyclic antidepressant, the top tricyclic antidepressants you should use, this is not just my opinion, various practice guidelines say the same thing, is nortriptyline or desipramine. Nortriptyline or desipramine should be your top tricyclic antidepressants due to several reasons, among which that they don't have prominent anticholinergic activity. So the answer is, this is a long way of saying, so the glycopyrrolate will work. Glycopyrrolate C is a symptom treatment. It blocks the sweating. It doesn't matter what is the cause of the sweating, it is going to block the activity at the sweat glands, so it can be very effective. But let's say, so it will work for nortriptyline, desipramine, tricyclic antidepressants that we commonly use. But just to continue, let's say, as our questioner probably intended, like what if you are using a tricyclic antidepressant that has potent anticholinergic properties? What then? And that is where it's a good idea. If the person already is having a lot of anticholinergic side effects, let's say they already have dry mouth, they have constipation, they have dilated pupils, maybe it's not a good idea to give them more anticholinergic medication, and that's why it's a good idea to have this second option, which is terazosin. So in that situation, that would be one of the possible situations in which I would consider adding terazosin to treat the ADs. Of course, it is true for all side effects that if you can change the medication or lower the dose, I mean, of course, that is best, but it's good to know that we have these options in case that particular medicine at that particular dose is absolutely essential for the patient. Next question is, what about buspirone adjunctive treatment for sexual dysfunction? These are all excellent questions because it is true that buspirone does work for a certain proportion of patients. There is a small randomized controlled clinical trial that has shown that buspirone does work for sexual dysfunction. So I absolutely agree with this. I recommend that if you are going to use buspirone, you should gradually go up, to 30 milligrams or even more to 60 milligrams. So it's not the question of using low doses of buspirone. One place where you might prefer using buspirone in contrast to other things is if the person could be helped by buspirone in terms of like they still have anxiety, or it also has some efficacy as an adjunctive treatment for major depression. So buspirone can be a good option in those patients where they need these additional benefits. I personally, in my clinical practice, have not had a great success with buspirone, unfortunately. And so it's not my number one choice for treating antidepressant-induced sexual dysfunction. But the truth is that nothing is an excellent treatment for antidepressant-induced sexual dysfunction, except maybe the PDE5 inhibitors like sildenafil or tadalafil, which work for male erectile problems. And therefore, it's a good idea to have a whole menu of many different options, and depending on the person's situation or the clinical profile, you may consider different things. So I'm glad this person brought up buspirone because it is correct that buspirone is one of the options for the treatment of antidepressant-induced sexual dysfunction. And the next question is, can you talk more about testosterone gel and use in women and your experience? So the important concepts in this regard are, one, that we should understand that testosterone is relevant for sexual functioning in general, not only for men, but also for women. That is something that is sometimes misunderstood. The people think it's only for men. So that's one important point I want to make. The second important point I want to make is that testosterone has a permissive role in sexual functioning. which means that if a man has lower testosterone level and you just give them testosterone, that alone is not very likely to solve the problems of sexual functioning. But if their testosterone level is low and you do other things but you don't give them testosterone, you don't correct that testosterone deficiency, then this other treatment may not work. For example, this has been shown in the case of PDE5 inhibitors like sildenafil and tadalafil, that if the person has low testosterone, then they don't work that well. The beauty of this thing is that it is so simple. All we require is a simple test. As we do our labs, you just order a serum total and free testosterone. That's how you should order it, total and free testosterone. Even though we are interested in the free testosterone level, obviously, the free fraction, but we measure the total because sometimes some labs, the free level is not so reliable. So just to be more careful, it's offered as a combined test. You might as well do it as a combined test, total and free testosterone. Now, the testosterone gel has been used as a treatment for specifically for antidepressant-induced sexual dysfunction, both in men and in women. There are randomized controlled trials from Israel and from the United States to support this in men and in women. I'm repeating. And so that's why we should consider this. So one, we should test for testosterone. Second, we should refer for possible testosterone gel. Now, the important thing here is please do not try to prescribe the testosterone yourself if you are a mental health practitioner. There are various precautions and there are various risks associated with treating with testosterone, which is why it's not a good idea for the mental health practitioner to be prescribing the testosterone gel. And so what I do is I have now in the last many years, I have a very low threshold for checking the testosterone level because I don't want any possibility that I'm missing testosterone deficiency. And so that's one thing. And I have been amazed at how often I do find a very significantly low testosterone levels. And then the other thing is to refer the person for treatment with the testosterone gel. Some of these people get like a lot of improvements in many different aspects of their functioning. So it can always be some degree of placebo effect, but they do report a sense of well-being and more energy, losing weight, as well as improvement in sexual functioning. But it is also going back to my original comment. It's not been my experience that if you give them testosterone, like most of them, that all problems are solved. You still have to do other things to improve their sexual functioning. But certainly this is an important thing that's not being done. And so I want to encourage people to increase the frequency by which they are checking testosterone levels and referring for treatment. The last question is, what is your website and what information can I find there? I have been a psychiatrist for like 29 years now, and over the years I've published many dozens of papers, I've delivered hundreds of lectures, I've done clinical research myself, and I became frustrated by the fact that many times, like a lot of the education we get is very theoretical, a lot of these graphs which are hard to understand even, and things which all look very interesting, but like when I'm sitting in front of a patient, I need a lot of different kind of information. I need all the details of exactly how to do something, exactly what to do step by step. And I don't have a huge amount of time to always be reading journals and so on and so forth. And people said to me, Raj, everybody calls me Raj, from the janitor to my wife. So you can call me Raj to R-A-J, Raj. So they say, Raj, we really like your teaching. It's so simple and it's so practical. And I realized that it's very difficult to find practical information which is written in a simple way that you can easily consume. And so I started this website, and so my website is simpleandpractical.com. So thank you very much to everyone who attended my talk on practical management of side effects and otherwise. And thank you to NEI Synapse, which put on just like the most fantastic meeting. And last but not least, thank you very much to you, the listener of the NEI podcast, for listening to this podcast. And I hope that you found it helpful in some way. All the best.
This wraps up our extended Q&A sessions from NEI Synapse. Look for the full recorded encore presentations at neiglobal.com.